Hello everyone, my name is Sebastien Janssens. I'm an ENT surgeon at the Jessa hospital of Hasslet, Belgium. I'm presenting to you the results of a large-scale cross-sectional phenotyping study that we conducted on a large series of P51S variant carriers in the COCH gene causing the FNA9. This work was conducted together with the University of Antwerp, and also other centers collaborated to this work, for instance, two Dutch centers such as the Nijmegen and Maastricht centers, and also Center of Medical Genetics of Antwerp. This work was also part of the doctoral thesis that I have defended successfully in June 2021 at the University of Antwerp. The FNA9 is a typical genetic disorder causing hereditary hearing loss, which is accompanied with bilateral vestibulopathy. It is a ninth condition that has been associated with a specific gene locus. As you know, hereditary hearing loss can be divided in two groups. You know, one group that is syndromic, which means that the mutation not only causes damage to the inner ear, but also other organs outside the inner ear can be affected. You also know, as the majority, non-syndromic hereditary hearing loss, where the inner ear is the only organ that is affected by the mutation. In that case, we see that the majority has autosomal recessive inheritance mode. In this example here, for DFNA9, we see that is a typical example of autosomal dominant inheritance. In case of autosomal dominant inheritance, we see that abnormal phenotype can already be caused by a mutation in only one of both alleles. In this case, one of both parents all represents abnormal phenotype. When they will have children, the odds of transmitting disease will be 1 out of 2, whereas abnormal phenotype is present when only one of both alleles carries the mutation. This is completely different in case of autosomal recessive transmission, where abnormal phenotype will only occur when both alleles contain the mutation at the gene locus. Let's go quickly further on to the main characteristics of DFNA9. DFNA9 is caused by a variety of mutations in the COCH gene, which is located in chromosome 14. The product of the COCH gene is cochlin. Cochlin is an important protein. It has been estimated to account for more than 80% of inner ear protein and has been attributed important functions for the maintenance of the architecture, but also for the function of native immunity, for instance by attracting neutrophils in the palymph as a response to bacterial invasion. COCH mutations are very numerous. Nowadays, more than 30 different variants, pathogenic variants, have been identified in all 5 continents. Every year, new variants are being discovered thanks to effective sequencing techniques. Only in Belgium and the Netherlands, we know 8 different variants. We also know that depending on the location of the mutation in the COCH gene sequence, we see that the phenotype can be variable. However, the P51S variant is an important one, since there are very numerous carriers that are living in this very restricted area, which is Belgium and the Netherlands. So in our region, it's prevalent. For the P51S, we see that on the nucleotide level, there is a substitution of cytosine to thymine at the 151st nucleotide, and after translation, you see on protein level a substitution of proline to serine at the level of the 51st amino acid, leading to an altered protein that is misfolding and cannot perform its normal function, which is deleterious for the host cell. We will now further go on, strictly limited to the specific P51S variant from now on. The clinical features of DFNA9 caused by the P51S variant have been established with genetic linkage studies and are already 20 years old. Typically, it is a late onset hearing loss starting at the 4th decade and starting at the highest frequency with a rapid progression towards lower frequency. Also very specific, typically, is the asymmetry of the hearing loss, which finally reaches severe impairment around the 6th to 7th decade. The vascular impairment has been estimated to start 9 years prior to the start of the hearing loss, also with asymmetric progression, leading to, in all carriers, to stages of bilateral vestibulopathy around the 5th to 6th decade. However, over the last 20 years, tremendous developments have been accomplished regarding medical imaging, genetic testing, and also new clinical tools have come up that we can use to refine our vestibular clinical vestibular investigation of the vestibular function. On the other hand, promising techniques are under their way, such as the vestibular implants and genetic testing for treating these diseases. This created new needs to find the most optimal therapeutic window for these new treatments, as well as, therefore, the better knowledge of a natural course of the disease has become essential. To the core business and to the results of the phenotyping study that we have conducted. We have managed to assemble data from 111 confirmed P51S carriers, comprising both Belgian and Dutch carriers, and this is the largest group ever until present to whom not only auditory tests but a whole battery of vestibular tests were administered, such as the CVAMP, OVAMP, caloric test using the video nystagmographic examination, and also the vestibulo-ocular reflex obtained with video head impulse tests, which gave us data from the 3 different canals separately, the posterior, lateral, and superior semicircular canal. We would therefore, by doing so, we obtained such as we can have for the audiogram an idea about the whole frequency range of the hearing. In this case, for the semicircular canal, we would obtain information at the lower limit of its frequency sensitivity range by using a caloric test, and on the upper limit by using VHIT test. Here you can see an example of the hearing deterioration. In this case, it is a case for male carriers at 1 kHz. You can see on the x-axis the raising ages, and on the y-axis the raising hearing thresholds. You see a dramatic and rapid decline of the hearing with age. And you draw a regression line, you see that there is a non-linear S-shaped regression line that you can draw here. We wanted to evaluate the age of onset of the hearing loss that is only caused by the genetic disorder, and therefore we had to find the crossing point between this non-linear regression line with the age reference limits that are visible here. The upper one is the 97.5, this is the 95th, and this is the 50th percentile line. And if we did this for all frequency going from 125 to 8 kHz for male and female carriers separately, and if you observe what happens at, for instance, 40 years, see the thresholds at the lower frequency for male and female, and you compare this at the same age for the higher frequency, you see that the hearing thresholds are already quite deviating from these age reference limits. And you can already also see that even at the youngest age group there is already deviation from the age reference limits, and this you can observe both for male and for female patients. So this is another way of presenting the hearing decline with the box and whisker plots. You see that visually that there is not really a difference between male and female carriers, but there is a difference in interpretation where you can see that the deviation from normality is reached in female carriers earlier than for male patients. This is due to more stringent age reference limits that are being applied to male patients in general, not only for DFNA9 but for all patients. The ARTA, referring to age-related typical audiograms, is another interesting way of depicting the decline of the hearing per frequency per decade. And you can see this ARTA for male and this one for female carriers. There is no difference in decline. Question remains, does vestibular decline really starts prior to the beginning of the hearing deterioration? And if it does, is it really with 9 years? So here the decline of the caloric function using the VNG test. On the left side you see the box and whisker plots, on the right side you see the scatter plots, and also try to find the age at which areflexia would be reached. Likewise we did for the hearing. However, we could not do this for those patient group with air irrigation because there is no clear stated definition for areflexia stated by Barani Society for the eye reflection with air irrigation. So we only used the patient group with water irrigation as a stimulus to compute this. Here on this slide, you can see the VOR gains obtained with the VHIT test. You see the decline here, which is resembling the decline of the hearing. However, this is a reversed non-linear S-shaped regression line. And we also we're searching the age at which this condition would be reached for all three canals, the lateral, the posterior, the superior, and an averaging of the three canals. On this slide, you can see the raising of the raising and disappearance of the CFM thresholds with age, and you already can see that at the youngest age group there is the thresholds were systematically higher compared to their control. This is a way of presenting the decline per subdivision of the vestibular end organ per decade, and you see that on the extreme left, the CVEMP are very quick to decline, followed by the VNG, and the VHIT are more robust over time if you compare this with the other tests. If you compare the canals by themselves, you see that the lateral is the latest to start its decline, and the posterior is the first one to start decline. We also established a deterioration sequence according to the location in the autovestibular end organ. And if you disregard VNG with air, since it is not really interesting, but the VNG with water only, whereas the blue triangles are representing function of the vestibular organ and all the red dots representing cochlear function, you see that the decline of the caloric function is preceded by high frequency activity or function, whereas the CVM is also very quick to start its decline, but the VHIT are the latest to start their decline. So to summarize, using the regression analysis that I explained to you before, we obtained the following results. The first to start function to start decline is a hearing function at 8 kHz, estimated around 27 years, followed by the CVEMP around 31 years. Then the remaining high frequency ranging from 32 to 33 years. Then the caloric test with water irrigation on VNG around 35 years, followed by the remaining hearing function ranging from 41 to 43 years. Then and only then are the first signs of decline of the VOR gains obtained with VHIT test at the level of the posterior semicircular canal around 44 years. At the lateral is the 45th years, and thus at the superior semicircular canal is around the 49 years. More details can be found in two big papers that we recently published in Ear and Hearing Journal. So the new insights for the phenotyping of DFNA9 are as follows. The vestibular dysfunction is indeed starting early, but it is not before the high frequency hearing loss, and is also not the case for the VOR gains obtained with the VHIT, which are latest to start its decline. This may be explained by the fact that we already have found signs on medical imaging referring to accumulation of deposits and inflammation. And this may explain also the differences between the results or decline sequence that we obtain with caloric function with regard to the high frequency acceleration that we obtain with the VHIT tests. The sequence of the VOR gain decline on VHIT test are as follows: first the posterior, then the lateral, and then superior semicircular canal. Ongoing work is about a multicentric longitudinal study where we follow especially very young DFNA9 carriers for the progression of both hearing and balance dysfunction. And multicentric studies means that not only 2 centers, but now there are at least 6 to 8 different centers scattered around Belgium and the Netherlands that are participating to this study. Why is that? Because, as I've told you before, we have seen that hearing threshold already deviated from age-related limits even in the youngest age group, ranging from 18 to 25 years. Remember that it is more difficult to identify male carriers due to more stringent age-related limits, but there is no differences between the decline of the hearing between both genders due to the mutation. The cochlear vestibular deterioration indeed occurs simultaneously. We have to refine the therapeutic window for future investigation. These studies can gain in better knowledge also in the pathophysiology of this condition. I thank you very much for your attention.